Usually, when we talk about a medical diagnosis, there's this expectation of precision.
Right. Wait, engineering.
Yeah, exactly. Like you break your arm, the x-ray shows that jagged white line, and the doctor just points and says, there it is. Broken or not broken. It's clean.
I mean, it's a comforting paradigm. We really like biological problems to be, visible, localized, and easily categorized into these binary states.
But then you step into the world of regenerative medicine and autoimmune disease, and suddenly that x-ray machine is, well, completely useless.
Oh, absolutely useless.
Today, we were looking at a fascinating medical collision for you. We're asking, what happens when a wildly popular regenerative therapy like a treatment that relies entirely on the healing power of your own blood is requested by someone with a disease that fundamentally alters their blood?
It really represents the ultimate biological paradox. I mean, we are talking about autologous therapies, meaning therapies derived from your own biological tissue intersecting head-on with systemic autoimmunity.
Right. And our specific mission for this deep dive today is to untangle the actual clinical protocol for administering the O-shot, which is a platelet-rich plasma, or PRP, treatment.
Right. But specifically giving it to a patient with active autoimmune thyroiditis, Hashimoto's disease.
Exactly. And to figure this out, we're synthesizing a really diverse stack of sources. We're pulling from specific clinical protocols, from O-shot providers, peer-reviewed research from the Journal of Sexual Medicine, some really startling case studies on PRP adverse events, and specialized research from MDPI on novel inflammatory markers found in Hashimoto's patients.
And the paradox we discovered in these sources, it really reveals a medical community that is just intensely divided.
Oh, massively.
Yeah, on one side, you have some doctors who believe performing this procedure on a Hashimoto's patient is a dangerous trigger. Like it could ignite a full systemic immune crisis.
Right.
But on the exact opposite side, cutting-edge clinics argue that this very same procedure could actually downregulate the disease itself.
Which is wild. But before we can even begin to understand why a systemic disease like Hashimoto's complicates things so much, I feel like we have to look at what the O-shot protocol actually entails.
Yeah, we need to know what it physically demands from your body.
So just broadly, the O-shot, or orgasm shot, is a non-surgical procedure designed primarily to treat female sexual dysfunction, reduced arousal, vaginal dryness, and, mild stress urinary incontinence.
Right, and it achieves this by utilizing PRP, which is platelet-rich plasma.
And to get that PRP, the protocol starts with a pretty standard blood draw from your arm.
Yeah, just a normal draw.
But the provider doesn't just inject that whole blood back into the targeted tissue. They take those vials and put them into a centrifuge.
Right, so the centrifuge spins the blood sample at incredibly high speeds. It utilizes centrifugal force to separate the blood components by weight.
So the heavy stuff sinks.
Exactly. The dense red and white blood cells get pushed straight to the bottom of the tube. And what remains suspended at the top is the plasma, the pale yellow liquid portion of the blood.
Which is now densely packed with platelets.
Yes. And the standard clinical protocol dictates that providers want to achieve a concentration of 4 to 6 times your baseline platelet count.
Right, which is huge.
Yeah.
I always think of these concentrated platelets and the growth factors they carry as the body's natural repair crew.
That's a great way to look at it.
We are talking about specific proteins like PDGF, platelet-derived growth factor, and VEGF, vascular endothelial growth factor. These are essentially chemical flare guns that your platelets fire off to tell your local cells to wake up and start building new blood vessels.
Which is a process called angiogenesis.
Right, angiogenesis. And they synthesize new collagen to rebuild the surrounding tissue.
So you're taking that endogenous repair crew, multiplying their local numbers by 5, and dropping them directly into a highly specific anatomical zip code.
Right. And the sources detail a total injection volume of about 4 to 8 milliliters of this concentrated PRP.
Which doesn't sound like a lot, but it is.
Right. The protocol requires injecting 2 to 4 milliliters into the anterior vaginal wall, which is commonly referred to as the G-spot area.
Yeah.
Then another 1 to 2 milliliters goes directly into the clitoral body and hood, and sometimes another 1 to 2 milliliters in the periurethral area, if you are dealing with stress urinary incontinence.
And the entire underlying assumption of this procedure, and really all autologous regenerative medicine, rests on a massive premise.
What's that?
The O-shot banks on the fact that your platelets are healthy, functional and ready to orchestrate a normal, predictable healing cascade.
Ah, which begs the question, what happens to those cells when a systemic disease like Hashimoto's is just boiling in the background?
Exactly.
We really have to look at the biological reality of this specific autoimmune disease to see why that healthy baseline assumption completely falls apart.
Well, Hashimoto's thyroiditis is a condition where the immune system mistakenly creates antibodies that attack the thyroid gland.
And it affects women way more than men, right?
Yeah, 8 to 10 times more often, which makes it highly relevant to female-focused protocols like the O-shot. But Hashimoto's isn't just a localized problem in your neck.
Right.
It creates a state of chronic systemic inflammation at the cellular level throughout the entire body.
And the MDPI research in our source stack goes incredibly deep on this. It shows that the systemic inflammation doesn't just, make you feel fatigued.
No, it's way more mechanical than that.
Right. Inflammatory proteins literally travel through your bloodstream, penetrate the spongy tissue of your bone marrow, and physically alter how your blood is being manufactured at the stem cell level.
It's wild. The MDPI paper focuses on a novel inflammatory marker called the PLR.
Which stands for the platelet count to lymphocyte count ratio, right?
Exactly. When you have a chronic inflammatory disorder like Hashimoto's, circulating cytokines act as messengers. They're constantly knocking on the bone marrow's door, signaling a state of ongoing tissue damage.
And the bone marrow's production line just shifts in response.
Yes. It starts churning out a massively high number of platelets in a panic response. And simultaneously, your lymphocyte counts. The specialized white blood cells that normally regulate immune responses, they actually drop.
Wow.
Yeah, so this resulting imbalance gives you an elevated PLR.
Okay, wait, I have to stop you there. Because if the entire goal of the centrifuge in the O-shot protocol is to get as many platelets as possible into the tissue, and Hashimoto's is making your bone marrow naturally overproduce platelets,
Right.
Isn't that a good thing?
You'd think so, right?
Yeah, it sounds like a biological head start. You're just bringing more of the repair crew to the job site.
I get why you'd think that, but biology rarely functions on a simple more is always better equation.
Okay, fair.
High platelet numbers absolutely do not equal functional platelets. We have to look at the environment those platelets were born into.
Right, the war zone.
Exactly. In a Hashimoto's patient, these cells are produced in a chronic autoimmunity-triggered war zone. So they are fundamentally altered. They are hyperreactive and deeply inflammatory.
Oh, wow.
Yeah, so if you take those specific cells, concentrate them 4 to 6 times in a centrifuge, and inject them back into a dense network of nerve tissue, you aren't sending in a neutral repair crew.
You're sending in the problem.
Right. You are heavily concentrating and injecting highly inflammatory cells back into your own body.
Which is terrifying. And because we are dealing with these altered inflammatory platelets, our sources reveal a massive, almost ideological divide in the medical community about how to handle regenerative treatment.
It's a huge debate.
It's like having a match, and half the doctors are telling you it will absolutely burn the house down, while the other half are looking at the exact same match and saying it's the only thing that will put the fire out.
That's a perfect analogy. Let's examine the danger side of the debate first.
Okay.
One of our sources details a deeply concerning case study involving a 41-year-old woman. She had an active autoimmune disease called alopecia areata, which causes the immune system to attack hair follicles.
Okay.
She went to a clinic and received standard PRP injections for facial and neck skin rejuvenation.
It's just standard PRP. And 2 weeks later, she developed a severe condition called serum sickness.
Yeah, it was really bad.
She broke out in erythematous wheals, which are basically widespread, severe hives right at the injection sites.
Right.
And she developed arthralgia, which is debilitating joint pain, alongside profound fatigue and a high fever. Her immune system essentially recognized her own concentrated platelets as a massive threat and just went into hyperdrive to attack them.
And documented risks like this have caused a whole camp of clinics and doctors to draw a hard line.
Understandably.
To them, active autoimmune diseases and inflammatory arthritis are either relative or absolute contraindications for PRP. They fear that introducing this concentrated inflammatory serum will trigger an unpredictable cascading immune storm that they simply cannot control.
But then you look at the other half of our sources, and they argue the exact opposite.
Right, the cure side of the debate.
Yeah. We have extensive data showing PRP being used to actually treat other autoimmune conditions. Look at lichen sclerosis, which is a chronic inflammatory skin condition that affects the genital area.
Yeah, that's a tough one to treat.
But PRP has been shown to be incredibly effective at repairing that specific tissue.
And the clinical data on vitiligo, where the immune system attacks pigment cells, shows PRP creating dramatic improvements there as well.
Really?
Yes. But the most compelling data is seen in rheumatoid arthritis. In animal models with RA, which is a massive systemic autoimmune disease, PRP injections actually alleviated the
What
arthritis.
really? It made it better.
It did. It decreased joint inflammation, reduced cartilage destruction, and objectively lowered the levels of inflammatory markers in the tissue.
Wow.
Specifically, it downregulated interleukin-6 and TNF-alpha, which are the chemical amplifiers your body uses to ramp up an immune attack.
Yeah.
So PRP actually reduced the localized cellular immune response.
Which is just mind-blowing. And one of our sources, the clinic of Dr. Noor Parvar in Los Angeles, takes this to the absolute limit.
Oh yeah, his protocol is fascinating.
He actively uses PRP to treat Hashimoto's directly. He performs ultrasound-guided intrathyroidal injections, meaning he's sliding a needle through the neck and injecting the PRP directly into the autoimmune-ravaged thyroid gland itself.
Right, to support tissue recovery and address the systemic hair loss associated with the disease.
So the core question is, how can the exact same substance cause serum sickness in one patient and heal the thyroid in another?
Well, the answer lies in the realization that PRP isn't a one-size-fits-all magic bullet.
Right.
The biological environment of the platelets matters immensely. Whether they act as a regenerative scaffold that promotes healing or an inflammatory trigger that sets off an immune storm depends heavily on the individual's current disease activity.
Like how well their systemic inflammation is being clinically managed at that exact moment in time.
Precisely.
Okay, so what does this actually mean for you as a listener? If you have Hashimoto's and you walk into a clinic requesting the O shot to help with intimacy or urinary incontinence, what is the actual clinical protocol?
Well, the sources outline a highly individualized, incredibly cautious approach. It is not an automatic denial, but it requires rigorous investigative screening.
Right.
The standard O-shot protocol from Zendesk does not explicitly ban autoimmune diseases across the board.
But it does have strict, absolute contraindications for other blood issues, though.
Yes, very strict.
Like you absolutely cannot get the O shot if you have thrombocytopenia, which is a dangerously low platelet count, or if you have clotting disorders or any active infections in the vaginal or urinary tract.
Right. But for autoimmune diseases specifically, the provider has to evaluate your current disease activity. The PRP contraindication sources from the Indo-British Advanced Pain Clinic classify autoimmune disease as a relative contraindication.
Meaning it depends on the context.
Exactly. Moving forward depends entirely on organ involvement and your general systemic condition.
And blood work is the ultimate decider here, isn't it?
Oh, absolutely. The doctor needs to see the objective numbers. First, they must verify that your thyroid hormone levels, your T3, T4, and TSH, are currently normalized with medication, like levothyroxine.
Okay, and why is that so critical?
Because if the thyroid metabolism is chemically stabilized, your bone marrow's platelet production and function begin to normalize as well.
Ah, okay. The provider will also likely look at that PLR marker to gauge the current level of systemic inflammation, right?
Yes. And they must check your hemoglobin, which needs to be above 10 grams per deciliter.
Just to make sure you have enough blood volume.
Right. It ensures you have sufficient blood volume for a safe draw and guarantees a high enough cellular yield for the PRP to actually be effective.
Now, medication management is a huge part of this protocol, too. You obviously stay on your thyroid meds, but if you are taking NSAIDs, non-steroidal anti-inflammatory drugs like ibuprofen or naproxen for autoimmune joint pain, the protocol strictly requires you to stop taking those 5 to 7 days prior to the procedure.
That's a crucial step. The mechanism behind PRP requires an acute inflammatory response.
Wait, I thought we didn't want inflammation.
Well, we don't want chronic inflammation. But when those concentrated platelets are injected, they need to release their growth factors. To do that, they have to synthesize prostaglandins, which initiates a tiny, localized inflammatory signaling cascade.
Oh, okay.
That acute temporary inflammation is the on switch for the healing process.
Yeah.
And NSAIDs are designed to chemically block the COX enzymes that create those prostaglandins.
Oh, so because NSAIDs are literally anti-inflammatories, taking them basically puts a chemical straitjacket on the platelets right when we need them to trigger that helpful acute healing response.
Exactly. The repair crew will essentially just sit there, chemically paralyzed. You will endure the injection, but you will not get the regeneration.
That makes total sense. But even with the blood work looking flawless and the NSAIDs cleared from your system, there is still that lingering fear of the serum sickness case study.
Oh, for sure.
If a doctor decides to move forward with a Hashimoto's patient, is there a way to test the waters? A specific protocol to ensure the match doesn't burn the house down?
Yes. A responsible regenerative medicine provider will utilize a highly conservative injection approach. For a first-time patient with an underlying autoimmune condition, the provider shouldn't just inject the full 4 to 8 milliliter standard dose right away.
Right. They do a localized test spot?
Exactly.
Yeah.
They prepare the PRP, but they inject a very small, conservative volume into a peripheral area first.
Okay.
Then, they wait and assess the tissue's localized response over a period of time. They're looking to see if the tissue accepts the PRP as a regenerative scaffold or if the immune system reacts with immediate severe inflammation and hive formation.
So they're literally just seeing which way the immune system flips.
Right. And only after confirming a safe, stable response will they proceed with the full dosing protocol in the highly sensitive anterior vaginal wall and clitoral areas.
It's all about respecting the complexity of your body. I mean, you can't just force a standardized protocol on a biological system that is already fighting itself. You have to work with the environment that currently exists.
Completely. It requires a really delicate partnership between you, your endocrinologist who's managing the systemic disease, and the regenerative medicine provider handling the autologous therapy.
Well, we have covered some serious ground today. Let's do a quick recap.
Sounds good.
So the O-shot uses a centrifuge to harvest your body's platelets to regenerate vaginal tissue, improve blood flow, and treat sexual dysfunction. However, Hashimoto's disease complicates this by altering bone marrow production, which results in elevated, highly inflammatory platelets.
Right. And this biological reality creates a huge divide in medicine. Some doctors view these altered platelets as a dangerous trigger for an autoimmune crisis, citing cases like the serum sickness we talked about.
Right.
But others look at clinical data showing PRP actively suppressing inflammation and healing tissue in other autoimmune conditions. Therefore, the clinical protocol for a Hashimoto's patient requires rigorous blood screening, normalized thyroid hormones, stopping NSAIDs, and a conservative test spot approach to ensure safety.
Which leaves me with a thought for you to ponder. If our own baseline inflammation completely changes how autologous therapies work if the exact same cells can act as a regenerative scaffold in one person and an inflammatory bomb in another, does that mean the massive clinical trials approving these regenerative treatments are inherently flawed?
That's a great question.
Right. Because if a trial isn't actively screening out patients with hidden underlying autoimmune markers, how do we know if the average results of these anti-aging treatments are actually real or just heavily skewed by the invisible health of the patient's blood?
It's a fascinating and honestly vital question for the entire future of the field.
Well, thanks for joining us on this deep dive. Keep asking questions, keep looking at the sources, and we will see you next time.